Welcome, Young Turk, for yet another session today with an interesting talk. This Young Turk activity, we know it's the dream and vision of our President, Dr. Pankaj Talwar sir, and our Secretary General, Dr. Shweta, to empower and nurture young Turks. So we do it every Friday, alternate, second and fourth Friday. So keep on remember, second and fourth Friday at 7 p.m. So today we have with us our Secretary General, Dr. Shweta Mittal. So yes, welcome, Dr. Shweta. You want to say?
Yeah. Good evening, everyone. Dr. Nisha, can you in the meantime put the message in the group that we have started the meeting?
Yes, I did, Dr. Shweta.
Yeah. Thank you. So I'm Dr. Shweta Mittal, Secretary General of Indian Fertility Society. So there were a couple of programs what we are running. I wanted to brief you all because there are many of us who are into private practices in government sectors. So one of course, is Young Turk, and it's a very interesting program. We would be not only presenting interesting journal articles, but now we have also thought that later we can have very interesting cases. So suppose you pick up a very good article, then you can present a case also along with it, which you have encountered with your senior, and then it can be followed by that journal discussion. Number two, like for example, today there is, this thing on ERA, if I'm not wrong, it's on ERA, right?
Yeah.
So we get a patient where we did 2 blastocyst transfers and they failed to implant, or they were, I think, more than that. And what started happening was that we were doing ERA. We offered her, the first ERA came as post-receptive. Then they asked us to repeat that ERA. And again, it came post-receptive in an HRT cycle. And then we realized that what was very important, even in an HRT cycle, is that you should do serum progesterone and estradiol level the day when you start progesterone. And surprisingly, without any evidence of any spontaneous corpus luteum, maybe she ovulated in between and escape ovulation, her progesterone came as 11, and that is why her window was closing. So, we then down regulated her, gave her, estrogen cycle, and then did her progesterone and estrogen before, doing an ERA. So very small things which need to be kept in mind. So we'll have a journal club, which will be very interesting. But the other programs, what I wanted to brief is that we have an AI program. So please join those webinars once a month. Then our Young Turk program is club with Kahoot quiz. It's open for all. A beautiful way of learning. You get certification and e-certificates are sent. We would also be acknowledging our young Turks who are presenting articles, and we would be sending, a certificate for that. Then we have a counselor empowerment program. So please make your counselors join it. They will be benefited. And at the end of, a particular module, we wish to come up with a checklist for all the centers and counselors, which will help them in counseling. We have our nurses empowerment program. Make your ART nurses or nurses in reproductive medicine or associated with fertility practice of yours. Join it. If they join 5 programs and they are registered with Nursing Council, they will get a certificate at the completion of the program, provided they attend all the programs. So these were our programs which I wanted to brief you about. And then, of course, self-empowerment is about yoga, meditation, and making yourself more stress-free. Last, I want to involve every one of you to our forthcoming, Fertivision. So I'm not speaking much about it because I can see Dr. Jayesh. He is an expert in this meeting, and he's going to tell that how interesting he's going to make this year's Fertivision with all the Gujarati hospitality. So we're looking forward, and we want you all to be a part of it. And last is that our membership drive has become very easy. So please become member of IFS and keep reaping benefit, what IFS is offering in the next, coming years. So thank you very much. And over to you, Dr. Nisha and Dr. Neeru, for the program.
Yeah, so we have lots and lots of activity. I'll name the another, we have another. Thank you, Dr. Shweta, for comprehensive overview. Now it's my great pleasure to invite expert of the day, Dr. Jayesh Amin. So Neeta, please share the screen. Welcome, Dr. Jayesh. Dr. Jayesh, we know, is the Dr. Jayesh is the clinical director at Nova Wings IVF Group, national advisor IFS, past secretary IFS, past Additional Joint Secretary, IFS, past Convener, Fertility Preservation Society, HOD at Nova Wings IVF training. And there are lots and lots of achievement in his practicing as IVF specialist and experience of 20 years, experience of 30,000 live birth through IVF, trained more than 200 gynecologists for IVF, one of the pioneer of day 5 embryo transfer, freeze-all, PGT and ERA. Role of embryo selection by AI technique in freeze embryo transfer, retrospective analysis in human reproduction. More than 5,000 successfully treated PGT-A, pioneer in immunogenetics, awarded excellence in IVF treatment by United Health Minister of India, awarded Times Health Icon in year 2021. And moreover, Dr. Jayesh, he is only local organizing chairperson for the Fertivisions. Yes, welcome, Dr. Jayesh.
Thank you.
Take the next slide. Yeah. So now I invite our young presenter, Dr. Nihita Pandey. She's MSCOG MS, currently a consultant at Indra IVF Institute, and very interesting topic on the ERA. Yes, Nihita, please come.
Evening, ma'am, and thank you so much for giving me this platform. So good evening, everyone, my seniors, my respected seniors, and my colleagues and friends. Today, I'll be presenting the paper written in 2023 by S.C. Arian et al. In this journal, Fertility and Sterility. The topic is of endometrial receptivity array before frozen embryo transfer cycles. And this is a meta-analysis and systematic review as to whether or not this is effective. So without much ado, let us start. So the study was conducted with the objective of investigating whether or not ERA had any impact on FET cycles and whether or not the success rate of live births and clinical pregnancies was improving. So with that in mind, they underwent a stringent analysis of all the studies present till date. Now, implantation failure, as we all know, is present in up to 30 to 50% of all embryo transfers. It could be because of many reasons, and this is the stuff of nightmares for most of our IVF specialists. And it's a very tough discussion to have with the patient, especially when we don't have any real objective or organic cause to tell to the patient. So the real challenge what arises is the definition and consensus of recurrent implantation failures. So especially if the patient is having recurrent implantation failures, there is still a lot of debate whether or not we should consider 2 or more than 2 implantation failures as RIF, and when should we start investigating the patients. And then again, the next question arises is, what are the investigations that we can actually afford to these patients? So one of these things is the endometrial receptivity. Endometrial receptivity was seen to be a challenge in some patients, and it was postulated that it is probably the receptivity of the endometrium which is faulty in these particular patients. And ERA being a chromosomal, it identifies 238 genes. So ERA was taken as a way of helping out in identifying these patients who can actually benefit with something called a personalized embryo transfer. So endometrial transcriptogenic profile was paired to computational model in some cycles and some studies, and this predicted what is known as the window of implantation. And the studies which were conducted on ERA postulated that personalized embryo transfer could impact clinical outcomes, and by studying these patients and transferring the embryo on the particular window, the implantation rate could actually be improved. So this meta-analysis reviewed all these studies, the different studies, RCTs, clinical trials, retrospective studies, which were conducted till date, and it wanted to examine whether or not ERA was actually of any utilization. So the study was Prospero registered, and they used PubMed, Embase, and Web of Science to detect all the studies. All the RCTs, the prospective and retrospective comparative studies, cohort or case control were included. And the comparative outcomes between ERA versus no ERA IVF cycles was the chief diagnostic thing. The quantitative outcomes, that is live birth rate, the ongoing pregnancy rate, the implantation rate, the biochemical pregnancy rate, the clinical pregnancy rate, and the miscarriage rate. These were the quantitative outcomes that were studied in all these studies. The exclusion criteria were review articles and standalone case reports, editorials, letter to editors, abstracts, and animal studies. And the outcome measures that was chiefly focused on in these studies was the primary outcome, which was the live birth rate, delivery of a live fetus after 20 weeks for the purpose of this study, and ongoing pregnancies were defined as pregnancies in which the live fetus was surpassing at least 12 weeks of gestation. And there were many secondary outcomes also that were studied, one being the implantation rate, that is the number of gestational sacs per embryo transferred. And the biochemical pregnancy rate were the pregnancies which were beta-HCG positive, but they did not have any GSAC at 5 weeks. The clinical pregnancy rate in which fetal cardiac activity was demonstrated on an ultrasound. Miscarriage rate, which was the number of spontaneous pregnancy losses in which GSAC had been demonstrated. So these were the secondary outcomes of the studies which were studied. There were 296 studies that they went through, and out of the retrieval of these 296 studies, finally only 8 studies could meet the inclusion criteria, and these studies were between 2018 to 2022. And in the studies, total of 2,784 women were included for the final meta-analysis. Out of these 2,784 women, 831 had undergone ERA cycle, and 1,953 women had not undergone any ERA cycle. Out of all the studies done, 2 belong to the United States, 1 each belonged to Japan, China, Spain, Latvia, and 1 was multicentric. There were 5 retrospective studies, 1 prospective cohort study, 1 clinical trial, and 1 study could not be defined as per the inclusion criteria. So out of all these studies, the meta-analysis was conducted. There were many sub-analyses done because the pool of data available was very, very heterogeneous. There were different types of studies available. Not all of them were RCTs. And once all of this was done and managed, they found that there was no significant difference in the ongoing pregnancy rate or the live birth rate, which is the primary outcome of the study, for either of these groups, whether they underwent ERA or they did not undergo ERA. There was no difference between the ongoing pregnancy rate or live birth rate of the pool of women. For the secondary outcomes also, like our implantation rate, biochemical pregnancy rates, they were also not found to be significantly different. The miscarriage rate was not very different. It was found to be the same in both these groups. So they concluded that there was no significant difference in the primary or secondary outcomes. They also did a subgroup analysis for women who had undergone 2 or less than 2 embryo transfers, and those women who had undergone more than 2 embryo transfers. And for this subgroup, they analyzed the ERA versus non-ERA IVF ETs. So if we, based on our definition of recurrent implantation failure, if either of these 2 groups we consider as RIF, even in these cases, they were not able to demonstrate any significant difference in the primary or secondary outcomes. That is, it was similar in both the groups, so either whether they were ERA groups or whether they were not ERA groups. So this is just a forest plot analysis. And in this forest plot analysis, the first, that is subgroup A, if we look at this, this is the primary outcome, that is the ongoing pregnancy rate or the clinical pregnancy rate. And we can see that most of these studies, they pass the line of no significance, except for 1 study, that is the O'Hara et al. Study, actually demonstrated that the primary, the clinical pregnancy rate, the ongoing pregnancy rate, live birth rate, they all improved. And the miscarriage rate actually reduced with ERA. But apart from this study, no other study was able to demonstrate any proper significance. The rest of the procedures that we have under B, C, D, and E, the groupings are that for the secondary outcomes, that is our clinical pregnancy rate, implantation rate, biochemical pregnancy rate, and miscarriage rate. There was no difference in either the ERA or the non-ERA group. This is what is tabulated in this table. Moving on. So when faced with this particular meta-analysis result, the authors wanted to understand why this has happened, because ERA actually, the way the advent of ERA was made to understand the embryonic receptivity of the endometrium, to understand the window of implantation. And it was postulated that if we implant or transfer the embryo during the window of implantation, when the female is supposed to be most receptive, it should actually improve our chances of implantation. And surprisingly, the study showed us that there was no significant difference. So what happens is we need to understand that window of implantation is not the only factor that determines whether or not an implantation will take place. There are several embryonic, many uterine etiological factors that can impact implantation. There are hormonal factors, molecular factors, many cellular events. There are many other facilitating factors like cytokines, the levels of cytokines in the body, in the local environment, the cell adhesion molecules, transcription factors, growth factors, and in fact, we also need a good quality embryo. It should be genetically good and also morphologically good. And there should be a synchronized dialogue between the maternal and embryonic tissues. So this synchronized dialogue is what is helpful when we are studying the window of implantation. But apart from this, the other factors is something that we are blind about in this study. We also need a receptive endometrium. So recurrent implantation failure possibly could be because of changes in the endometrial receptivity. And in fact, a lot of studies had said that the window of implantation can be shifted in around 25% women with recurrent implantation failure. But because the definition of recurrent implantation failure is so varied, it is very difficult to actually understand the underlying causes for it. Many other factors apart from endometrial receptivity, like we earlier discussed, one being the uterine microbiome, the immunological factors. So your abnormal function of uterine natural killer cells, the high TNF levels, and interleukins, pro-inflammatory interleukins, high TNF levels in the local environment can also facilitate failure of implantation. And one important factor that we have not studied in the particular analysis is that of aneuploidy and embryonic causes. So ambiguous outcomes for recurrent implantation population regarding ERA happened in this study because the study is actually very heterogeneous. One of the limitations of the study is that they are not based on completely clinical trials or RCTs, and that is what we require. When they were going through the literature survey, there was one study that had suggested that there is some synergistic effect between immune profiling and personalized embryo transfer. So what does this mean? What they were saying is that if we only do personalized embryo transfer, if we only focus on ERA and we transfer the embryo in the window of implantation, but at the same time, we also do the immune profiling of this female for TNF alpha and for natural killer cells. And we also study the patient for her immunity, then there is better chance of that pregnancy continuing. And so there is synergistic effect between the two, is what was postulated by one study, but because it was just one standalone study, we could not really test it further. So at the end of the day, what it says is the window of implantation is solely not sufficient for success. And all these other factors that we have discussed before also need to be considered. The dark side of ERA is that it is very expensive. So it causes a financial burden on all these patients who are already undergoing a very expensive IVF treatment. It is also invasive and it needs time, resources. And of course, because it is invasive, it comes with a small risk of injury, infection, or bleeding to the patient. So it raises the question that without any hardcore proof of whether ERA is or helpful or not, should we be suggesting this test to our patients, and how should we be counseling them if we are presented with a case of recurrent implantation failure? So there were some studies that said that instead of the window of implantation and the personalized embryo transfer window, it could also be the local endometrial injury which is being caused by ERA. And the procedure of ERA is actually akin to scratching, and probably the patient is actually benefiting from this procedure of scratching and not ERA itself. But further meta-analysis was studied, and they found that the role of scratching on positive clinical pregnancy rate or live pregnancy rate is unclear. And so there was no further comment made on this particular thing. So what we know as of now is that we require a better understanding of the physiology, the immunology, the molecular mechanisms which are involved in implantation. And we are still at a very early primitive stage when it comes to understanding the implantation mechanisms. And also at the same time, we need more advanced ERAs. We need to study more specific genes which are involved in implantation, and we need to study the cellular factors so that we can come up with tests which are far more specific. So like I mentioned, there are multiple limitations in the study. If we just look at the conclusion, it might appear to us that ERA is actually not helpful. But what the study is telling us is that we need to take this with a pinch of salt, because this study has analyzed many studies which are very homogeneous. There are some retrospective studies which are not very powerful, and there are basically different types of studies. The chief thing that our meta-analysis tells us is that there is a high need for having more clinical trials and more RCTs so that the outcomes can be studied. And at the same time, we need to understand that when the patient population is being included, we need to standardize certain aspects of the patient population. Things like the HRT cycle, which is given, the type of when the ERA is conducted, the type of embryo which is transferred, the morphology of the embryo which is transferred, whether or not these are tested for aneuploidy by PGT or NICS. These things need to be standardized in the study so that all these confounding factors can be removed, which were not being done in this particular study. And once we can ideally create such an ideal study, only then we'll understand whether or not ERA is actually helpful or not. So most of the included studies were retrospective. Separate subgroup analysis were conducted, but obviously they're not good enough. So heterogeneity of the studies that are included is a chief limitation of this current meta-analysis. There were different types of ERA kits, testing modalities, different types of endometrial preparations in these studies. And then there was again no control for causes of implantation failures other than endometrial non-receptivity, like the embryonic causes, PGT, and in fact, even immune profiling. So this is the need of the hour, that we need to come up with a study that can actually control the population that we are studying for all these factors. So the conclusion remains that we are unclear whether ERA results in an increase or decrease in pregnancy rate among patients undergoing IVF-ET cycles, and we need well-designed RCTs, and that is the need of the hour. And this add-on procedure should be integrated into routine clinical practice only if it is proven to have any clear evidence of efficacy, utility, and cost effectiveness is justifiable. So with that, I would thank you all, and I'm open for questions.
Thank you, Dr. Neeta. It's an excellent presentation. So, Dr. Jayesh, you want to
Yes.
make any comments?
Yes,
Next slide, Neeta.
there are a lot of comments from my side.
Yeah, this is yours.
Because
You
I gone
can-
through my own publications in the Curious Journal of the of the European Journal. And it is around 219 patient study. And I think so we performed around 128, 219 patients, which is around 79 patients, those who are having a non-deceptive ERA will be there. So my conclusion is very clear to look into this meta-analysis. See, for ERA, one thing is more important, that where you are sending, because data is important. How much data is collected, the library is so important. So we don't have something like that. What is the library status of the genetic clinic is there, first thing. Second, I've seen something, most of these studies are retrospective, I can understand. Even the retrospective study, because my study is also retrospective. But retrospective study give some insights of the utility of the test. And there is a time now to not to see the meta-analysis. There is a time to see the RCTs. So I don't believe in the meta-analysis because it's all about the collection of a lot of things. And ultimately it gives a wrong impression. So we are always putting it in our practice. And so that's why rightly, nicely stated, lastly, the RCT is needed. Third thing, in my study, what I said that it is around 15 to 22.5%. So I divided in donor oocyte and I divided in the self also, right? And let me tell you something, it's so important that if you have you should have some criteria that when the Indian female, those who are having a less than 33 years of the age, then after 4 qualitative blastocyst transfer, freeze embryo transfer, then you can go, you can offer the ERA, right? Now, if your age is more than 35, then you have to increase the number of the embryo. But as what I did in my study, that we had offered also PGT also. So my around 84 patients are having a PGT. So when you do PGT, now I am telling that whatever my experience that I am doing ERA in every month is all our patients, those who are having a PGT failure. Already the patient has already transferred in America or everywhere, any part of the world, they transferred 1 or 2 PGT normal embryo. So when it is a PGT normal and morphologically normal, you should always see what is the morphology of the embryo, because PGT and morphology if not correlated, then again there is no role of ERA. So this is most important, that PGT and PGT was done. And if there is a single embryo transfer, right? Because it's all about somebody is always allowed to go to embryo transfer. I still believe that now we are shifted around 80% in my clinic that we are using single embryo transfer because of the immunology science. So single embryo transfer, one embryo 2 times. If it is failed, then I used to always say, now you have a 2 test which is required, which is called ERA and immunology. Now crosstalk is important. Now timing is important. So as such, we don't know the hierarchy. If you don't do PGT and if you do only ERA, then it will mimic the output of the ERA. PGT is always higher than the ERA. Most important that in my study, I already say if I do only ERA, then my result is only 34% in recurrent implantation failure. But when I do PGT plus ERA, my result goes to 77.7%. Right? So what is my suggestion? That combination. So if you don't do PGT, only PGT will reduce the effect of the ERA, only ERA will reduce the effect of the PGT. But PGT is having a major effect, that what I'm saying in my study. So here all the meta-analysis, we don't know the library, we have not gone the morphology of the embryo, we don't know the exact the number of the embryos transfer, we don't know the PGT which was not included. And as Dr. Sweta Mittal says, in my study, I already downregulated all the patients. Serum progesterone was done on day 2 also and day 11 also.
Yeah, always we do
So
it.
all my study, in my study, I'm still doing in day 2 and day 11. Even I'm downregulating my patient with the antagonist. I still believe that it's not like that. It's only 7 to 9% people, those who require downregulation. Rest of the people don't require downregulation, right? But when you do study, and specifically when the recurrent implantation failure, you should not make a window like of increased progesterone. So all recurrent implantation failure, I will down regulate it with the antagonist for 7 days. First 7 days. There is a publication that if you don't want to give agonist, then you can give a first 7 days, you can give antagonist 0.25 milligram with estradiol validate, then there is no ovulations, right? So I had done the same thing in my study and transfer genetically normal. I have got a lot of case series. I'm always putting this is very interesting topic for me. And I say something about that day in and day out in my practice. I will say PGT failed 2 times, 3 times, then ERA window period is 151. I transfer in 84 plus or minus 3 hours. I transfer lowest day 5 embryo in 76 plus or minus 3 hours. Right? So it is not consider, this meta-analysis will not consider that this test is non-significant.
No,
And
no.
by
we
putting
can
it the
say
conclusion
yeah,
that ERA is a very good test when you have an implantation failure. But
Yes.
sometimes it will not give a, because many of, when you collect the patient, it may be associated with the immunology rejection also. So when PGT failed, it's a hands on hand. It is not only ERA, but immunology rejection. So now we are working on the immunology rejection, specifically on the recurrent pregnancy loss. That PGT embryo, if you transfer 3 times and all are pregnancy loss. PGT ERA and you transfer the embryo, all are no implant. Then what to do next? This is what we are now interested, because now we are over with the PGT plus ERA, but we are opening the black box of the immunology. There is a huge discussion. I'm ending with here that ERA is a very good test, should be applied on a morphologically good, should be applied in a selected patient, should not be applied without PGT, right? So if you are having a 2 failed FET and next time you do FET and you are doing ERA, rather than you do PGT embryo transfer, and if it is failed, then applied ERA. Right? This is
Nita,
what
can
the
you
message
see next slide, please, Nita.
I think the message is that individualization is the key. So you need to
Yes, yes.
select your cases where you want to do it. Dr.
Nita.
Nita, there is a question for you. This was ERA before the first FET or after the first failure?
First,
Ma'am,
I think I should welcome a legendary person of the IFS, Dr. Pankaj Talwar, sir. He has joined. So I think, sir, you want to give your, please unmute. So first we should take your, I think, mentoring.
Thank you so much.
session.
Thank you so much. I think it's nice to see everyone here.
Yeah.
Neelu, am I audible to you?
Yeah,
Yeah,
good
yeah.
evening, sir.
Hi,
You are.
Dwayne. How many people are there? 90 people are there. Can we say hello to
Right.
everyone?
Yeah.
Can we, are they all, we can't see them. Yeah, can we, guys,
No, it's your introductory
Can we-
slide she has put on. So we all know Dr.
Hi, sir.
Pankaj Silva, sir.
hi.
He's the president of IFS, CEO at Homa Fertility and IC Training Academy, Gurgaon, as well as Delhi. Dean, Department of Clinical Embryology and Reproductive Science, Sridhar University, Pilani. President IFS at present, PhD in Clinical Embryology, founder of Global ART Sister School. There are so many publication in his award, past HOD and director of ART service, Birla Fertility, founder secretary, Fertility Preservation Society, awarded Vishish Seva Medal, awarded with Tapisar Lifetime Achievement Award, trained 1700 students globally, icon of North India, Economic Times Award, experience setting 29 books, best research paper by DGAFMS, member of Infertility Committee, conducted more than 150 workshops, commissioning editor FSR, edited 9 books, more than 100 publication, experience of 17,000 OPO and ET, trained in human embryonic stem cell derivation, Israel, trained in ovarian cortex freezing, trained in PGD and DQM, Germany, Spain. So welcome, Dr. Pankaj. Welcome, sir. Yeah. So I think you can screen share, you can leave.
Yeah, thank you so much. And my only aim is to just say hello to all of you. And I was just hearing whatever was happening. And so, great job. And same with for Nisha and Jayesh for holding the fort today. I just share my screen with you people. I hope you can see my screen now. Is it visible to you all?
Yes, sir. Yes, sir, it is.
Yeah. So guys, thank you so much for being with us. And I bring you greetings from the Secretariat, Indian Fertility Society. And you all know about our society. We are around 4,500 in number. We are present over 29 chapters. So actually, when this, I just give my vision for you people. We got a big vision for you people. And this Young Turks group has been created for people less than 45 years of age, barring the mentors who can join. And I'm so happy that we have more than 750 people who have joined our group and who are constantly interacting with all of us. So the vision for Young Turks is year 2035, how we look at our group of infertility doctors. All of you will be the future in the coming few years. With this vision, the Young Turks group was created in the year 2017. So 17, 18, 19, we have grown. The number is touching nearly 800. And I'll just give it to you, you people are the future of the world, the future of the country, not only in terms of IVF, but looking at the overall growth you people have. So today when Niru and Nisha told me to speak few words, I was really honored to speak to you all. We have heard a lot about ERA and PGS and PGD debates. I heard Jay speaking pretty well. So in case you look at the way our country is growing, I've got a more global vision for all of you. How the country is growing. Look at this number. By 2035, India is going to become a $10 trillion economy in the world. Look at this number, mind-blowing. By year 2048, India will be the second largest economy in the world. And probably in a few decades or so, it may become the biggest economy of the world. So 2048, 50 is what we are looking at. 2049, another picture shows India as the biggest economy. So worldwide, India is slotted to be the biggest economy in the next 10 to 15 years. And I'm sure you'll have to shoulder the responsibility. All of us, all of you who are at 35 to 40 years of age, you'll be the people who will be carrying India on your shoulders. You'll be the giants at that time. It'll be your time, your era. I just want to give you certain thoughts of mine. We are actually living in the world of applications. We live in the world of cloud. Everywhere you find certain things moving, and we're surrounded by the information. What Nisha told me 2 days back that you people don't speak. So we realized one thing, that probably, we had kept the the settings in a different mode so people can interact. Are you people able to see my screen?
Yeah,
Yes,
Are you
yes,
people able to see my screen?
definitely.
Okay. Okay. So everyone is muted?
Yeah,
Everyone is muted here?
yes.
Can you unhide their videos, please? I like to see my friends. I like to see them. Can you put the
Camera
videos
on,
on
everyone
and
please, camera on.
their also? Let us see them. I want to see our young Turks. Who are they? How they are doing? Shouldn't hide. Hi Arun, how are you? Hi Rajapriya. So I'd like to see all of you for a few minutes and then we'll move ahead. So this is a journey I'm gonna share with you how IFS has grown, and you guys must talk. I've been constantly finding that the young generation doesn't talk. You guys must talk. And I'll tell you a very short story about not talking. There was a gentleman who was a very busy guy. And one fine day decides that he will gift his wife something very nice. Wife was very angry with him. His wife was very fond of pets. So he goes to, Pali thought he'll buy some diamonds or something, but he thinks he should buy a pet. So he wants to buy for her a little kingfisher or something, very nice bird. Goes to a shop and he buys a little rabbit for her. The shopkeeper tells him that why don't you buy something more exotic? Buy for her a talking pigeon. He says, but why should I buy a pigeon? How much? 500 euros. A pigeon is costing €1. 500 for the pigeon. He said the pigeon can talk. This pigeon can talk. This pigeon can communicate. The pigeon is Alexa enabled. He is Amazon enabled. He can talk in multiple languages. He is doing his PhD in embryology also. He's already done a fellowship in IVF. Very qualified pigeon. He'll look after you. He's very happy. He takes a pigeon that he's going to give his wife some company, and he gives his wife this pigeon like this. And he says that, okay, sweetheart, sorry for everything in the life. We're going to live well. Today evening, I'll come, we'll have dinner together. Leaves the pigeon with her. In the evening, when he comes back, the wife is ready with champagne glasses and wine, and they want to have dinner. As they were having a dinner, wife says, hold on, I'll get the main course, and she get this. He says, what is this? He says, a pigeon. She says, but why we cook this pigeon? He was so talented, very wise pigeon. Why we cook the pigeon, barbecued the pigeon? The pigeon never told me that he was talented. So in case you don't tell how good you are, who will listen to you? So all of you must talk, all of you must interact, all of you must volunteer for young clubs, must volunteer for quiz. Dr. Arun is waiting to continue with this quiz. You must express yourself. In case you want to express, you'll get barbecued. That's one message for you. Second message for all of you is that you're working so hard. How many of you prioritize yourself? Can you raise your hands? How many of you prioritize your own life? How many of you prioritize your own self? Does anyone do it? Or you're working around the clock all the time? Anyone? Yeah, Divya, you prioritize yourself. Very good. So I think you should all prioritize your own life. And the life will just carry on. Rama Reddy, great. Good to see some volunteers raising their hands. And remember that sometimes in the life, do the things tomorrow. Have courage to say no. Do things tomorrow. And sometimes you say when you're tired, don't hurry. Just be happy. Let it go. Do it after 3-4 days. I want to show you a little nice video here. I'd like to see anyone talking and tell me what is the answer. Any volunteers? You'll all be barbecued otherwise. What's the message from the video which you just saw? You can't unmute.
Speak up.
Yes, you can all unmute yourself.
Please unmute all.
We just spoke about getting barbecued, and it's still not talking.
Sharing is caring.
They're supporting each other.
Hi.
No,
What did you learn from this video?
we all contribute to each other's life and practice, and that's how we all will grow.
Yes, you can't grow alone. Take people with you, you'll always grow better. This is one lesson. Whatever big things we do in the life, that's great, but take people with you. That's very, very important. I'll give you one more small little video for you to watch. Little video for you to watch again. And let's see the video well. This is the story of all of us. That's a life. It is also very good, like yes, what is the lesson learned here? What do we see here in this picture, in this small video?
Evolve over time.
Yes, yes, Manisha.
Evolve over time.
We all
Evolve over time.
evolve and watch around you. Work with a good
Evolve
team.
over time. Yes, with a good
Yes,
team.
work with a good team and take the whole people with you. This is a very nice picture. That this is what we are. When we are talking to everyone, you people don't talk. You people are so shy or you're so busy. Remember that we must take advantage of the general clubs, take advantage of knowledge. Because when we have everything and we are saying no, basically we are very busy and we are thinking. So knowledge in our country, look at an exam system. We have a different set of exam system where everyone is expected to do a particular thing. So we tell a seal, probably a dog or a fish or an elephant, a penguin, a monkey, a snake to climb a tree. But that's not the way you learn. So I think all of you are different and IFS caters for different way to groom you people, train you people. I personally feel as an elder brother to all of you that all of you should not only get focused only on studies, but develop some extracurricular activities also. Do some fun and learn more. This is why I tell everyone that try to use minimal amount of social media until it's very, very relevant. And social media is the one thing, this killing all of us. So can someone give me a small idea that how many hours a day you use your social media? How many hours in the day you use your mobile phones? Any guesses?
2 hours.
It's around 3 hours. And in a whole life, 6 years we are using mobile phones. 6 years we're using mobile phones, and in 1 year, we spend around 3 months on mobile phones, which is of no relevance at all. This is the picture I show to all the young Turks as a message that, whenever we are having a problem, half of us don't react. We say, किसी के घर में हो रहा है तो मुझे क्या फर्क पड़ने वाला है. I think we should all become a community, and IFS is a community where we all work together, we do hand holding, so that everyone's whole is plugged together and we all grow together. We also firmly believe that we should all row our boat in the same direction. This is what we want to do when everyone should walk in the same direction. This is a picture. Third is the fourth habit, which I want to tell you all, is that we should eat less and look at your health. We all should sleep well, look at your health along with getting education. And the whole world of chaos, try to spend some time on yourself where you internalize and stop having chaos. Get more clarity of thoughts. Now, suppose today we heard a beautiful talk on ERA. We heard Jayesh talk about PGS. Must go home and give clarity of thoughts to yourself and get an answer. And always we should use the right tool. Now, what to use, when to use ERA, when to use PGS, when to not do anything of that nature. Many times, I don't think you may not require both the things also. Take the right tool, the right method to work, and every day you must improve minimal 1%. So this is the rule of marginal gains. In case you gain 1% every day, you will gain around 38% at the end of the year. In case you spend our time more on social media and just whiling away your time, we come to 0.03% negative at the end of 1 year. Very important that every day we should learn a new habit and work well. So to appreciate, we have to always keep our classes full, keep educating ourselves and sharing the knowledge with the people. This comfort zone. You must study hard, work hard, have a good life balance. That's a message from me in my life. I worked like you long time. I'll stretch your comfort zone, come out of it, but always have a life balance. And until you're desperate for knowledge, you can't get knowledge. So you have to work very, very hard. And always I tell everyone that don't go in for perfection. Present in journal clubs, participate in the quiz. You may not be perfect, but you must participate. And as you participate, learn more and gradually we evolve. And I also say, as I end my talk, that the best brains of the nation will be found on the last benches of classroom. You need not be brilliant, but need to be balanced, a hardworking person. And in case you really want to do well in the life, you want to shine like a sun, must burn like a sun. So with this, I will end my little message for all of you. I thought I'll keep my talk away from academics. We talk about nation building. We should talk about how to build you people up. That's my message for all of you. So I think that's all from my side. Do well. We must be waiting for the quiz now. So I thank you so much for being with the IFS. Thank you so much for joining this lovely group of people. If you need anything from us, feel free. Just give us a call. We got two big meetings coming in the next few months. We got Fusion coming. You would have heard about ESHRE, ISAR, IFS Fusion coming to the country. The whole of ESHRE is coming to the country now. You must take advantage of that and you must participate in the ESHRE meeting. That's at Jaipur. We are calling it a Fusion meeting. The So December, we are having our meeting that's called Fertivision. You must be part of that. You want to play any role in that, you want to be a chairperson or you want to be there in some way, you can always contact us. We are there to help you. You can talk to Jayesh and we can all help you to grow. I think that's all from my side. Thank you so much for giving me the chance to speak to all. And thank you so much, Neeru. Thank you so much, Nisha. And Jayesh, thank you. And Arun, all yours now. I think I'll say goodbye. Thank you.
Thank you very much. Thank you, sir, for the valuable messages. You are always a source of inspiration to everyone. I think few questions were there. We can quickly take these questions. Nisha, you are here?
Ma'am, I'm here, but you can take the questions, please.
Okay.
Dr. Neeru, after question, just I'm requesting that I have only 7-10 presentation of Fertivision, so I will present it at the end of the question answer also.
Okay, okay. So we'll quickly take these questions. Can ERA be, it's by Dr. Neeraj Jindal. Can ERA be applied if another cycle of simulation started after one failed IVF cycle and ERA was done before that failed cycle? Dr. Jayesh?
Can ERA
be applied if another cycle of simulation started after one IVF cycle and ERA was done before that failed cycle?
See, we are doing, let me tell you something. When there is a 2 implantation failure, there are 2 ways of doing ERA. One thing is you start before the cycle. Let's say you are stimulating the second stimulation. Before that, you can do ERA, and then you can make the embryo, and then you can transfer the embryo. That is a one way to go. Second, what I am doing in my clinic, that I will make the embryo, I will do PGT normal embryo formed, then I will do ERA. After waiting 1 month, then I will do ERA, and then I will transfer PGT normal. So this is the 2 way to go ahead, because I believe PGT is more important. You should have to have a PGT normal embryo in your hand and then perform ERA. That will be great.
But they say like if we do adjacent cycle, then the results are accurate.
No. What I want to say that your cycle should not be have a stimulated, right? Should be silent. So you do start ERA first. One thing you do suppose you are having a 2 implantation failure. Now patients say that, okay, I have a 2 FET failure. Now what is the reason, doctors? We say, okay, we can perform PGT first, because if you don't transfer 4 embryo in younger population, might be possible out of 4, 1 embryo should be PGT normal indirectly. So it is the now next cycle when I perform ERA, I can say I will perform ERA and I can transfer 2 embryo again. As you are young, I will not perform PGT. That is one way. But then you never know that failure in one cycle, second cycle, she might got a pregnancy. So I will do PGT ERA first cycle. I will do stimulate. I will do PGT, and then I can transfer the embryo in the projected ERA window period. This is one way to go forward, where you do ERA first. Second, I am doing, suppose I stimulated the cycle, I will do PGT normal embryo come. So in the month of July, and already everything is completed. August, I will wait. September, I will do ERA, and October, I will transfer. In between cycle, I will never do ERA, because it is always going to be a disturbed window period, adjacent cycle of the stimulated. That is what my study and my experience.
Yeah, so there is no month of stimulation in between. You have done adjacent to that. That you wanted to know.
Yeah.
Definitely. How useful is ERA in achieving pregnancy? Yes, we get useful also in many cases. Heat map analysis. Is ERA result reproducible in further cycle? Let's say after 3 months, after 6 months.
See, previously they will say something about ERA is a permanent test. Now they are coming out that after 2 years, you have to do again perform the ERA. Even if you perform the ERA previously, and after 2 years they are coming for the implantation, the remaining embryo, then you should perform ERA. I still don't have my data, and I am still performing that the previous ERA which was already done. But I think so. This is what the study says.
These studies say that we have results are not reproducible after so many years. And what is the cost of ERA, EMA, and ELISE test? Time for result to come. Collective cost of everything, if we do, it will be around 1 lakh.
So I think so. ERA. Still, I believe that I don't believe in the sending the ERA report to any laboratory. I still believe that Pioneer is Genomics will be there. I'm still adding. I don't want to compromise because library is very huge.
Yeah.
So it should be used because people are asking that Dr. Jayesh, you give me a sample to produce my library. What it means that they don't have a library. So don't go ahead like that with the very lab, those who are not having a used library data. That is more important. Now, second thing is that in ERA, the cost they are charging, if you do PGT ERA combined, so unlimited ERA and that they are giving 1 lakh rupees. If we do only ERA, then their cost is around 42,000. And if you do only MI and LS, they are costing around 25,000. So this is ERA plus MI LS costing around 65,000. But then you should take your charge. So that's why Madam is right that we can charge them 1 lakh rupees at the end of the day for ERA MI LS phase.
And LS.
Yeah.
And time for result is around 20 days. They take 15 to 20 days for results. I think it's over. We are over with the questions. Dr. Arun is also waiting. Anyone have any other questions to ask? For how many cycles ERA result is valid?
That's why I say 2 years you can have a same ERA. So any cycle, second cycle, you should not do ERA if you are doing a one transfer within a year. I still don't have my own data that I have transferred in the previous cycle with the 151 plus or minus 3. And second time, if I do ERA, then I need to do ERA again for that patient. Then whether it is not which time, but I do have a implantation in the same ERA period when I transfer the second baby when the previous ERA report. So I still not confirm because you require a lot of data for that how much time it should be valid.
So Jay sir, I will add one thing. I have done few cases where I have done ERA. The patient conceived after ERA, and then they come for a second baby after 1.5, 2 years. And we utilize the same thing in one patient, and we repeated ERA in one patient. The results were same, like the ERA time period was same. So we did a second transfer according to the same thing.
That's why I'm saying that everybody should have to have a huge data to say something where should not repeat.
Yeah. I have also done one patient after 3 years for the next pregnancy, and the results was good.
But I think individualization is the key here.
Yeah.
To summarize, I would just say that, sir, would you like to summarize what the take-home messages from our talk?
One last question, what to do, it's by Dr. Harshita. What to do if no pregnancy after normal PGT and ERA? Yes.
That's a very good question, and that is what I am doing. And it is a PGT ERA every day in, day out. I have one patient in my clinic that they done PGT ERA anywhere else. And where you have to do the, I am doing, but it's a huge lecture on the HLA typing and how can you interpret this HLA of the husband and wife, that why they are failure. So it will be a huge lecture, but HLA is another one report that you can always say. But if you want to a PGT ERA, always explain the patient when you consider this immunology science, you should have to have at least minimum 2 or 3 transfer. So don't allow them to do immunology before 2 or 3 transfer, because 2 or 3 transfers always they will get entry inside the immunology system of any female in the world. After 3, if it is they are not entering, means their immunology is very easy. They are rejecting the embryo, and now we need to find out that what is the test that we can know that we can do that. By that we can come to know that her immunology is rejecting the embryo 75% or 100%. And then we have to apply something like that donor LIT or individualize the patient. Who required donor LIT, who required something low molecular weight heparin, who required prednisolone. So we are having a lot of data now, 200 patients, recurrent pregnancy loss as well as recurrent implantation failure, both are important, where we can apply crosstalk and immunology science. I think so it's a big day for discussion. So I will conclude that opening the immunology box is the answer. Now, after PGT ERA, if they fail, right? Opening the if endometrium is more than 7 mm, no Escherman, uterus is no adenomyotic, Why the obesity with the not more than 32 BMI, and she's medically fit. Even you have a PGT era failed, then immunology is the answer. How to open it, that we have to keep one more session. So I will conclude it that I am doing by HLA testing of husband and wife, that we will discuss later on.
Yeah, thank you.
Thank you so much. Would you like to invite for fertivision, sir?
Yes. That is my main.
Nihita, can you put the slide, please?
I'm just sharing. I'm sharing my slide.
Okay.
I think Nihita, you can stop sharing. Sir wants to share his slide.
Yes, I made something which was. Yes, Kabir. 1 minute. So
make it full screen, Dr.
Yes, I'm doing. I think so. Now full screen is visible to you. My slides are visible to you, and I'm
Right.
audible. So this is about the Fertivision 2024. To young trunks, let me tell you, my vision is just like what Dr. Pankaj Talwar says, that whatever the seniors are here, the gray hair years, they still want again come back the same conference, the physical conference, with a lot of people, those who are really in the learning attitude. Because we know that people are making a lot of efforts in the conference, but at the end of the day, our conference are making more entertainment and less, means all are empty sometimes. It's really not good for us. And that is why I request all the young chunks that this is the conference that I'm trying. My mission is very clear, that we are matching the same the aura of the international conference that we are visiting, and actually the timing, the people are sitting, everything, that I'm trying my best. Let's see how we are successful. I need help of everybody, those who are IFS member. We are 4,033 member. Look at that, 4,033 member. And let me tell you something, if we are 4,033 member, if 50%, those who are having the IFS patriotism, that I am an IFS member and I should visit IFS conference, then we should have at least 2,000 gathering should be there. But still, we are so much sad to say that we are not reaching that count. And that's why I am starting my slide, that requesting all the people that even 50% we can reach. 4,033 members are there. So I request all the IFS member on the outside of this platform and to young trucks, that this is the very good conference coming in Gujarat, in Ahmedabad. Mahatma Gandhi Convention Center is just like an international convention center of the ASHRAE or any ASRM conferences. It was made like that. And beside that, we are having all other program in the Hotel Leela. So you can have a good hospitality at the end of the day, because Leela is known for that. Now, this is what the people, those who should attend. We have a completely that we can have a level 1 doctor also. They want to improve their practice. For that, there is a one workshop, right? What exactly they can improve the fertility practice. Those who are starting their clomiphene citrate, antioxidant, referring the patients, early stimulation, they can also come. Second, level 2. So IVF beginners, those youngsters now jumping inside the IVF practice, that how IVF beginner level 2. And the most important, those who are already have a more than 5 years practice, we have a lot of workshop like for the genetics, for the embryologist, and a lot of advanced immunology inside there will be there. It's none of them like that. Embryology also, we can have a 5-7 workshop for embryology is there. So it's not only for clinician, the embryologist, a lot of things are together will be there. So you can come and update your knowledge, rectify your knowledge. This is the video I'm not going to show you. This is the how you can see the video of the Hotel Leela, It's amazing. It is just like a resort which was created in a what we can say it's a palace resort. So it is amazing infrastructures and outside it looks very amazing, gorgeous look will be there. Now let me tell you that we have a Hotel Leela. This is our brochure which I'm sending. These are all our academics, our senior doctors are involved. The most important part is I will like to share that these are the workshop. You can have these all workshop that level 1, level 2. I designed like that. Sonography, then you can have a laparoscopy, then you can have embryology, then you can have a genetics, then you can have a AI, then you can have a certain things which is called preservation. So everything. So my theme is very clear. Theme is tailoring, that how you are going to tailoring yourself in your clinical condition. Transformation, that means you have to transform your practice nowadays. You cannot just go and get the aerial view by helicopter. Now you should use the drone. So
Dr.
as
Ganesh,
technology will change,
request by
right?
Dr. Arun to wind up fast. Please
Yes,
wait.
yes. And this is all our international, the who's of who, all the international speaker. So I will like to request all good morning message. I'm putting all, these are the international speaker. Request all to just to attend this conference. It will be wonderful at the end of the day. Without your help, I couldn't make something that we need IFS people. This is my request. All 4,000 IFS warriors or the people to attend this conference. Thank you so much, Dr. Neeru and Dr. Nisha, madam, all that to make me a expert and to make me allow to me to present the Fertivision 2020.
Thank you, Dr. Jayesh. These all young Turk will be there. So everyone is going to come. Yes, welcome, Dr. Arun. And yes, you can start your case. Thank you very much.
Thank you, Dr. Neeru. So, all the participants for quiz, I welcome you all. This is the third episode of, or the third in the line. First was on fertility and law, and second was on endometrium and fertility, right? And now this one is the third, is on ovary and fertility. So for this episode, we have Dr. Rajapriya from South Zone. She's the zonal coordinator for South. She'll be conducting this quiz. Before I give mic to her, am I audible, no?
Arun sir, good evening. Dr. Nisha here. Dr. Rajapriya is traveling. Her train got a little delayed. So she has a patchy network. She said that she would be observing. She would not be able to, conduct the quiz. But I think we can. She has already submitted the questions and everything. So
I'll
we'll
do
be
it on her
running
behalf.
on her behalf.
It's fine. I'll do it on her.
Yes, sir. Yes, sir. Please, sir. Please, sir.
I'm audible, no?
Yes, sir. You are audible, sir.
Okay. So anyway, so before I just want to give some introduction for this quiz. This is a great concept by President Dr. Pankaj Dalwar and the Secretary Dr. Shweta Mittal. So this is basically an idea that we interact more, and whatever we learn, we can judge ourselves a bit, that how much we learn, what have we learned, and how much we can remember. Dr. Nisha, am I audible? I know somebody is writing that.
Sir, you are audible. I can hear you very clearly.
Okay. Thank you so much.
I think, Dr. Nisha, you have some network issue. Yes, sir.
Okay. So the name we kept was Genius Junction. And what we decided was that we will have every month, that's a monthly quiz on Kahoot. So anybody and everybody from all over the country can participate. So we will have 5 winners from here, and 3 of them will be eligible to participate in a semi-final quiz to be conducted in Ahmedabad at the time of Fertivision. So all of you who have won in the previous quizzes and this quiz also, you will be there for the Fertivision, right? And there will be another link where we will have the winners from every chapter. Okay. So 2 winners, 2 means 2 teams from every chapter will participate in that zonal quiz. And from zonal quiz, we will have 2 teams from each zone. That means 10 teams who will also participate in the semi-final. So we'll have 2 amalgamation in the semi-final. One is from the chapter-wise quizzes, and the second one from the national quiz which we are conducting now. Okay, so from the after semi-final, 5 teams will go to the final, which will be conducted again at the time of conclusion. So that is the plan. And so coming on to, already we are very late, we start with our today's quiz. I request the host to please, help us in sharing that. Okay. So this is the pin. Once you open your Kahoot, this is a pin that will be asked by the Kahoot. So enter this pin and you will be there, right?
Sir, I want to announce everyone that you should log in with their numbers, not names. Everybody should log
Yes.
in with their phone numbers. No names.
So yes, so at the time of finding the winner, that becomes easier for us. Come on, friends. Hurry up.
मैम इसमें ये वो पूछ रहे सैंपल टाइप कौन सा लेना है एंट्री सिस्टम में ना यही आ रही है तो कंफर्म कर देंगे कौन सी लेनी है
अच्छा, please, अभी आप सुन लो।
Hemali, you need to change it to your number. Miss Hemali, Sumati Saxena, please change to your number. Don't put the names, please. Hemali, please change to the phone number. Guys, please
Saxena,
join.
please change your number.
Guys, we have 82. How to start this game? Sir, I think some of them don't know. Maybe we can again explain. They need to download the Kahoot app. And at the base of the Kahoot app, there is a small dice. They need to click on that dice and then log in.
And once you log in, that the Kahoot app will ask for a pin. And there's a pin on the screen. You can put that pin. Hemali, please join. Sumati Saxena, please join with your number. If you are unable to do, please exit and then rejoin with your number. Okay.
Guys, everybody needs to download the Kahoot app. On the Kahoot app, if you log in, there will be a small dice at the bottom. Something like we do in Ludo. Shubhadeep, it will start only once you put the pin which is given at the top. Click on the Ludo icon, click on that icon, then put the pin which is given there. We are about to start, so please be fast.
JYO, please join. JYO, please join with your number.
Guys, only 31 still. We are 86 people. 75. Please join. Sir, how much time do you want to give more?
Give another 2-3 minutes. Let me get more
Okay,
the
sir. Okay, sir.
Isha, I'm unable to see how many people have already joined.
Sir, it is written there only on the board. At the bottom, you will see 31 people are there. On the Kahoot screen, at the bottom right corner, you will see 32 people are there. Now 34.
Friends, please join. It's a great opportunity. Once you qualify for semi-finals and the finals, there are plenty of gifts for you.
Guys, the gifts are very exciting. Starting from, you won't even believe what a mega prize is going to be. So please join fast. Very exciting prizes. Come on, fast.
Let's start, madam.
But sir, once the quiz is locked, nobody else would be able to join.
Yes, I understand.
Yeah.
It's already 7:20, no?
Mr. J, please join with the number. Sir, so you want to start now?
Yes.
Okay. Okay, Shivam, please lock and start.
So the first question is, what is primary function of theca cells of ovarian follicle? 1. Option is produce estrogen, produce androgen. Second, produce progesterone and support oocyte maturation. Fast. 30 people have answered. And produce androgen is a 20 people have answered. Good. Next question, please. 8765 948. Good. Next question is, what is the number of oogonia by 16 to 20 weeks in human embryonic ovary? 9 to 11 million, 7 to 9 million, 6 to 7 million, 4 to 6 million. Thirteen people have said 6 to 7 million. Good. Next question, please. At the top of table is 7288 184.49 number. Mark score. Progression of meiosis to diploid stage is accomplished at what gestation of pregnancy? Till 12 weeks of pregnancy, till 20 weeks of pregnancy, till 28 weeks, till birth. Till birth. 11 people have done it rightly. Next question, please. At the top of scoreboard is 8333. Score of 2384. Good. Next question is, ovulation is considered to occur 28 to 30 hours after the beginning of the LH surge. 8 to 20 hours after the LH peak, when follicle reaches over 1.8 centimeter size, all of the above. All of the above, 22. Good. Next slide, please. Coming on the top is 6403, 2384, and 2384. Again, another. What are the favorable estradiol level per follicle to predict pregnancy? 199, 200 to 229, 299, 399, none of the above. 2 seconds said, one said. Good. It is 200 to 299 picomole. Good. Next slide, please. So on the top is 8333 backup, 3209 score. Which condition is not a differential diagnosis of PCOS clinically? Cushing syndrome, acromegaly, non-classical CAH, panhypopituitarism. Panhypopituitarism. Good. 24. 833 has slipped down to third rank. 84129 at the top of the table. Come on, guys. AMH is produced by theca cells, granulosa cells, adipocytes, mesonephric duct epithelium. Granulosa cells. 27, correct. The top of the table, 8156. And which is not the ultrasound feature of PCOS? Follicle number by ovary more than 25 at 8 megahertz frequency probe. FNPU more than 12 at 6 megahertz. Ovarian volume more than 10 cc. Follicle size up to 10 mm more than 12 in number. Which of them is not? Follicle size up to 10 mm more than 12 in number. Oh, friends, PCO. Score topper 84129 by 443. Which enzyme converts testosterone to DHT, dihydrotestosterone? Aromatase, 17 beta hydroxysteroid dehydrogenase, 5 alpha reductase, 17 alpha hydroxylase. 5 alpha reductase, 24 done it correctly. Thank you. Next slide, please. At the top is 64132 with score of 6245. So syndrome X includes all except hypertension, hypothyroidism, endometrial hyperplasia, and dyslipidemia. Three have done it rightly. Hypothyroid. Next slide, please. At the top of the table, we have 64132 with score of 7155. See, if you do in a lesser time, the quicker, the better score. Laparoscopic ovarian drilling indicated in all except persistent high LH, anovulation with CC resistant PCO, hyperandrogenic PCO, hypogonadotropic amenorrhea. Great. 32 have done it correctly. Hypogonadotropic amenorrhea. And the top of the table is 64132 79564. Next, please. In Turner syndrome, like 45X, loss of germ cells is due to what? failure of migration of germ cells, failure of mitosis of germ cells, failure of meiosis of germ cells, and all of the above. Correct answer is failure of meiosis of germ cells. Only 7 have done it. Next slide, please. And the topper is on the top of table. Is still maintaining lead. 64132 is with score of 7956.
Congratulations. Buck up, everybody else.
DHA is synthesized in the ovary, adrenal gland, testicle, or pituitary gland. Eight have done it rightly. Adrenal gland. Next slide, please. Wow, the topper has changed. 72706, the score of 8903 on the top of table. Recommendations in POF include all except fragile X pre-mutation testing is indicated. Gonadectomy should be recommended if detectable Y chromosomal material. Chromosome analysis must be done in iatrogenic POI. Screening thyroid antibodies should be performed. Correct answer is chromosome analysis must be done in iatrogenic POI. Next slide, please. Go top of table is 7288 with the score of 9076. Faster you answer the question, more score you get. Cyclical bleeding in which duration of menstrual cycle is reduced to 21 days or less is termed as what? Menorrhagia, epimenorrhea, metrorrhagia, or dysmenorrhea? Epimenorrhea. It is also called as polymenorrhea. No? If it is less than 21 days, polymenorrhea also. That is another term. So maintaining lead is 7288-1001 score. Please hurry up. Diagnosis of adolescent PCO is to be made after 5 years of post-menarche, after 6 years of post-menarche, after 7 years of post-menarche, or after 8 years of post-menarche. Very easy, faster. Wait, after 8 years of post-menarche. You don't make a diagnosis till 8 years. 7288 is the topper, 10953 at the top of table. PCOS phenotype D includes the following. AO, HA, PCOM, HA, PCOM, hyperandrogenism, PCOM, amenorrhea, PCOM, amenorrhea, HA, hyperandrogenism. Anovulation, basically. A is anovulation. So anovulation with PCOM is type D. Top of the table, 7288, score 11788. Making a comeback is 8333 also. Fact about serum AMH, that is not true. Serum AMH is lower in those with higher BMI in the general population. Serum AMH may be suppressed by current or recent contraceptive use. Serum AMH should not yet be used in adolescents. Currently a diagnostic test for PCO. Seven six two seven seven, score 12004. Next slide, please. Ovarian tissue cryopreservation, only viable option for prepubertal patients. Experimental method, ASRM. LBR 8.7%. A and C are true. Great. Next slide, please. Bakapet 333. Post-surgical recurrence rates lowered following for ovarian endometrioma includes ablation, cystectomy, drainage, or CO2 laser vaporization. Good, cystectomy. Next, please. So we are done with. The topper is, the winner of the day is 9003876277. Number 2 is with a score of 1263, 16 out of 20 correct. And the second place is on the podium is 8801608333. Buck up, score of 12437, 15 out of 20 questions. And third on the podium is 9953448765. Congratulations, everyone. Now, I would request the host to please allow these people to put on their videos. I'd just like to see their faces.
Yeah, please unmute
The
all. Please unlock all videos.
Done, ma'am.
Yeah. Guys, anybody wants to say something? I think many of you don't know how to log into Kahoot. Sir, please, can you explain one more time?
Yes, sir, sure. So you have to download the Kahoot app, and then down there below there is a dice. No, dice is something like which you play Ludo with. Once you click on that, then you have to put that pin number which appears on the screen which at the beginning of quiz, right? Once you put that, then you are logged in. And what we have done is we try to include the basics also, because what I always understand is that unless you know the basic reproductive endocrinology, it is very difficult to really understand infertility. So the many questions will be from the basics also. So then you go on to the advanced in form of maybe graph version or the latest technologies, right? So don't try always that all those difficult questions will be asked. There will be more of the basics going on to. Okay, the question is what is the topic for next quiz? Next quiz topic is on uterine factors and infertility. It will be on 26th of July, right, Harshita? And it will be conducted by East Zone Coordinator, Dr. Nikita. Host, I would request the winners to please say a word. I'd just like to see their faces, right?
Good evening.
Yes, please.
Good evening, all. I'm Dr. Yukti Bhardwaj. I've come third in the quiz today. Thank
Great.
you for the.
Congratulations. Congratulations, Yukti.
Thank you.
And
congratulations, Yukti.
I would
hear the first two.
Thank you, ma'am. Thank you so much.
Who's second?
Maybe the first and the second person also should come up and introduce themselves.
Yes.
You are muted. You are Srinidhi, you are muted.
Good evening, ma'am. I came first. Thank you for this opportunity, ma'am.
Great.
Congratulations.
Thank you.
Thank you, everyone. I would like to extend my thanks to Dr. Rajapriya, sir, Dr. Shweta, and Dr. Pankaj sir for giving the young Turks this opportunity.
Word from Secretary Madam Shweta, she's here.
So it was really amazing. I was there throughout the quiz. Very interesting questions. And you know what was really nice that we are having more and more participants. And I was getting some message from one or two fellows also. So I think it's really interesting and it's a big hit. So over 70 participants is great.
Dr.
It's
Shweta,
really hard work of the whole quiz committee.
Dr. Shweta, what we have done is we starting from the basics and going on to the latest advances, right?
So
because
one
what I
quiz
wanted to-
before fertilization should be the toughest.
Yeah.
Yeah,
Questions
sure.
were great. All the questions were great.
Yeah.
Thank you, everyone.
Okay,
Dr.
thank
Shweta,
you.
Dr. Ansabir is here. Madam, sorry,
Yeah,
on
yeah.
your behalf, I had to
Sir,
conduct
sir,
this.
you saved my day, so I was losing signal in between. So who has come second, sir? Who's the second winner?
First is Srinidhi, third is Dr. Yukti, and I don't know who is the second one.
Yeah, I will be happy to see the second one also.
Yeah.
So we can wish you well and say a good night to all of us.
Okay, good night, everyone. Thank you so much. Thank you.
Thank you so much. Thank you.